So yeah, I mean, it's exciting to be here amongst you both as a member of the Saudi Arabian Interventional Society, as the Saudi Health Council board member, as an employee of the Ministry of Defense and the King Fahd Armed Forces Hospital, but just as one of this community, a woman cardiologist who sees women and treats women. And I think it's amazing that we're having this conversation. So again, thank you to the Emirates Cardiac Society for this initiative and for taking it to the next level, finally. So in my capacity as a woman and as a mother, as a wife, and as a sister, and so on, it's always a balancing act when we're looking at women's health. What is the balance? The balance is, it's not unique to me, it's not unique to my mother, it's not unique to women in this part of the world. As family members, we always put our families first, and our health, our well-being, our mental health, everything takes backstage. Because we think we're doing the right thing. Slowly, we're learning that that's not correct. In order to invest in our families, in order to be productive members of our community, we need to take care of our health. And that's where the balancing act really comes in. So, popular dogma about women and their health is really, when it comes to cardiovascular health, is that women are protected from cardiovascular disease. And when I finished my training in the US and came to the Gulf region and started practicing, that was very common. You sit in communities with women, and the discussion was all about breast cancer. It's all about self-examination. And nobody really was considering cardiovascular health and cardiovascular diseases in women, because the impression was that women, particularly those who remain in reproductive age, were protected from cardiovascular disease, and so fewer women die from cardiovascular disease. So what does it really look like now in 2020 and 2022 and so on? So this is from the Global Burden of Disease that was published in 2022, really looking at data up until 2021. What we do see is that rheumatic heart disease, ischemic stroke still lead the cardiovascular mortalities. And interestingly, rheumatic heart has actually gone up in terms of morbidity and mortality. But has cardiovascular mortality really changed since 1990, over the course since we've been tracking it? And is there really a difference between men and women? Well, let's look at it together. So the purple is 1990 and the green is 2021. So we're looking really at a span of over 2 decades. And what we do see is an improvement. So whatever it is that we're doing, prescribing statin therapy and encouraging a healthy lifestyle is somewhat working. But what you do see is there really is no difference when you look at the different age brackets in terms of men and women. They are equally likely to die from cardiovascular illnesses. But let's look at our region a little more specifically, the Middle East and North Africa. When you look at the general trend since 1919 until 2017 at least, and that's the more current data that is available, you do see that it is slowly coming down. But let's look at it one at one. So the first thing that catches your attention is Kuwait. The numbers are actually lower than the rest of the region. I don't know why that is. I don't have an explanation. Perhaps this is something that we need to be looking at as cardiologists in the region. And there's a tendency or a trend for it to come down. But then what is also striking is when you look up, when you look at places like Bahrain and you look at Qatar, their mortalities has been the highest. But then again, they have achieved over the course of 2 decades a steep decline in the mortality rates. What have they done there that was correct, and what should we be adopting? Again, let's keep looking at, for example, Saudi Arabia, and we look at Oman. The trend, they were sort of in the middle, they remain in the middle, and the trend is slowly declining. What isn't very much declining is in terms of the Emirates. What you see, it's mild decrease, but it's more of a plateau. So I think this is what I tell my patients when we're looking at LDLs and when we're looking at RBS and when we're looking at blood pressure. You look at trends, you look at patterns. Are we heading in the right direction, or are we heading in the wrong direction? And so we all need to be decreasing with all the effort and the number of cardiologists. We really need to see this coming down. Again, let's look at very closely leading causes of death in 1990 and then again in 2017. What you do see is that cardiovascular disease, disappointingly, remains the leading cause of death. You look at maternal and neonatal disorders and mortalities and morbidities, thankfully, they are actually decreasing, and it has gone from number 2 to number 10 in 2017. So we are doing something correct there when it comes to cardio-obstructors, perhaps, and so on. But what remains static as well is looking at transport injuries. We haven't improved in spite of the highways, in spite of the expansions and so on. It still lies at number 5. So there are trends and there are patterns that we need to be looking at as healthcare workers. A lot of the focus, and I'm sure you know that in your own practices, is a lot of the focus is on coronary disease. A lot of the research is on coronary disease, but cardiovascular diseases is more than just coronary artery disease. Atherosclerosis, it can be peripheral vascular disease, and again, as I said, the trends lately is showing that rheumatic heart disease is climbing, and that's where we had the steepest incline in terms of cardiovascular disorders and disability-adjusted life years. Perhaps the peripheral vascular disease, the reason we're seeing it more, or at least capturing it more in our registries and the data, is because we're looking for it more. We're actually aggressively doing ABIs a little more often than we used to over a decade ago. But even though, as I mentioned, rheumatic heart and peripheral vascular disease are going up, what you do see, whether you're looking at Afghanistan, whether you're looking at Egypt, Saudi Arabia, Kuwait, etc., when you're looking at ischemic heart disease, it remains the bulk of the disorders. And of course, there are environmental risk factors that we don't even consider, and unfortunately, these are not matters that we discuss, but perhaps we should be discussing them in 2023. Metabolic risks, of course, we have started the conversation over a decade ago about lipids, about hypertension, smoking, etc. And smoking and dietary habits, sedentary lifestyles, behavior risks. Again, the conversation, fortunately, has already started. Which takes us to the next. Risk factors. Are they different when we look at men and women? Well, this is a woman I think I have tremendous respect for, Nanette Wenger and her group in Emory. They published this in 2013, captured data from 2013 to 2017, and they looked at how do you do risk assessment, then after you assess these risks, how do you stratify them, and then how do you move on and prevent them? So naturally, they looked at, for example, when it comes to lipids, the 2013, which were the most recent guidelines then before their publication, and really looking at how you want to stratify them. So looking at history and physical and so on, but also considering coronary artery calcium scorings, ABIs, and so on, to give you combined risk stratification. And then moving from that to actually encouraging lifestyle modifications and not just drug therapy. But what we do see that is different, and I was just talking to Dr. Khadija, a diabetologist, is that the number of diabetes has actually increased across the globe and not just in the Middle East and not just in the Gulf region. But what we do know is that diabetic women are more likely to develop and die from cardiovascular disease than their male counterparts who have diabetes. We do need to be a little more aggressive there. Hypertension, again, over the age of 60, it's more prevalent in women compared with men. Dyslipidemia, unfortunately, dyslipidemia population attributable risk is the highest, certainly in Saudi Arabia, and it has been so over the last decade with no significant improvement in our initiatives. Obesity, this is data from United States. However, again, obesity in this region is also increasing. And why is it increasing? Well, it used to increase because the awareness about moving and so on wasn't there. And even as we started to improve in terms of encouraging a less sedentary lifestyle and a more active lifestyle, we've regressed in the last few years. Part of it was perhaps COVID, but part of it is the new generation of men and women and children who have iPhones and iPads and just want to sit, and you can order fast food, and it's just become easier to be more sedentary nowadays. And then smoking, sadly, it is still increasing, and it's not decreasing in our part of the world, and it actually has a greater relative risk in women compared with men. So again, we know what we need to do when it comes to risk factors. Back to Nanette and her group, have the atherosclerotic cardiovascular disease risk factors changed over the last decade, and do men and women have different risk factors? So when you look at this, when you look at the traditional risk factors or conventional risk factors of hypertension, diabetes, dyslipidemia, et cetera, and then some of the non-traditional, such as depression and environmental factors and so on, these are actually combined. These are not limited to men. And so actually, this is shifted to the middle. But what is unique to women is pregnancy, low birth weight, menopause, hormonal therapies, et cetera, and autoimmune diseases. But as we are paying attention to women's health, and I think this is a misconception, is that it's unique to women. As we learn a little bit more about women's health, we're learning more about men's health. So actually, autoimmune diseases, HIV, and so on, also impact cardiovascular health of men. And we've learned that. And guidelines, for example, the ACC lipid guidelines have clearly reflected that for both men and women. So autoimmune diseases is something we picked up as we paid closer attention to younger women developing cardiovascular diseases, but learned that it impacts men as well. So again, I focus quite a bit on coronary disease, but we do know that ischemic stroke risk exists, right? And although the global disability for ischemic stroke was equal between the sexes in this 2019 publication, sex differences varied by year, location, and age, but mostly attributed to the disproportion of cardiovascular risk factors between men and women, where women had more hypertension and so on. So considering the population growth and the aging, which is happening in our part of the world as well, comparatively, yes, compared to the West, to Europe, to the United States, our population is younger. The age of the first myocardial infarction happens at an earlier age in our part of the world. But when you compare it to a decade ago, the population is starting to grow. We need to be cognizant of that, and we need to start addressing risk factors, cardiovascular disease, and have the health system ready to accommodate all of this. So more individualized prevention is what's necessary. And interestingly, again, this is reflective of ischemic disease, ischemic stroke. What you do see in terms of differences between men and women, tobacco, dietary risks, alcohol use, etc. But really tobacco is a big one, and that is a big difference between men and women, although the rate of tobacco consumption is increasing in women. And then you also look at dietary. Those are quite significantly different between men and women. But something that we're not addressing adequately in both men and women is the impact of environment. And I think we do need to start talking about pollution and its impact on cardiovascular disease now, in 2023, before we start to see the impact in 2033. But this is an important publication from colleagues here in the Gulf region that I think we all should, as we talk about women's health, we need to look at it very closely. It was done by Dr. Shihab and his colleagues, and it actually looked at age and sex differences in patients with AMI, and it looked at the 7 different Arabian Gulf registries. When you look at the different age brackets and you compare men and women, you do see that in the younger age group, fortunately, more men are actually in the group that they in that registry. But over 75, you start to see more women captured in the registry of the Gulf. Again, when you look at body mass index, you see those who are lower weight were in terms of men compared with women. And when you look at ethnicity, non-Arab actually was higher in men, and it's natural because those are probably the workforce in the Gulf region. But then when you look at history of MI revascularization, be it PCI or be it CABG, again, what you do see, sadly, is that men are more likely to have had it than women. So women, you do see more de novo disease. But then looking at heart failure, you look at stroke, you look at diabetes, hypertension, etc., clearly there's more of it in women compared with men. And then the only other thing is current smokers, current or ex-smokers were more likely to be men compared with women in that registry. And then we move to something else that we've all seen in clinical practice. Women are more likely to have atypical symptoms. Now it's time to, discuss this once and for all and put it to bed once and for all. So the 2021 chest pain guidelines that were published by the American Heart Association in collaboration with ACC and the CT community and CMR and so on, actually want us to move away from the terminology of atypical. So women are more likely to have accompanying symptoms, so they may have more palpitations, they may have syncope, sweating, etc., and nausea, but actually their presentation is predominantly chest pain. So when a woman comes with chest pain, don't brush it off. It is most likely something worthy of investigation, particularly if she has risk factors. And then what is in now is non-cardiac. So investigate, make sure that this is not cardiac symptoms, and let's make atypical a more obsolete terminology. We should say is suspected, is not suspected, but atypical is really misleading, and it's really discouraged in the latest guidelines, primarily because we end up being very dismissive of these women. So again, let's go back to this Gulf registry, which was very informative for us. We look at women and we look at men and we look at their presentation in terms of chest pain and in terms of heart failure and so on. In terms of chest pain, yes, the men is actually this column over here. I don't know if you can see my bar, but it's the second column. So the second column is the men compared with the third column, which is the women, and you do see they are more likely to have chest pain than women, but again, they're also more likely to have KILIP class 1, and women are more likely to have a more advanced KILIP class 2, 3, and even 4 compared with men. And when you look at LV function, once again, when you look at it, you see that more men are likely to have a normal or preserved LV function. When you look at symptoms to hospital arrival, those who present within 3 hours are more likely to be men compared with women, so there's delayed presentation. And then when you also look at those who come symptom to ED, again, is significantly longer in women. We're talking about 160 minutes in men, and we're talking over 225 in women. And then when you continue, so now they're in the emergency room and they came with this chest pain. So again, you continue to see consistent delays, whether you're looking at ER presentation to the emergency room, to ECG, or to needle, or to cath lab time. Again, it's consistently longer in women compared with men. So that's on us, and not just the education part, on women who are presenting late. So women are less likely to receive guideline-directed medical therapy after we've diagnosed them. So now we've moved on from symptoms to management. Again, we're failing the women. So whether you're looking at whichever age bracket, you're looking at revascularization, whether you're looking at in-hospital mortality, again, compared with men, women are less likely to get revascularization, be it CABG or PCI, and they're more likely to have accrued in-hospital mortality at 1 year that is higher, especially in those who are less than 65 years. So that's something that we need to address as a community of cardiologists. But we also need to improve awareness and campaigns and so on for at least the symptom portion. So there's part on us and part on the patients. We've addressed the disparities. They're there. They're glaringly there. They're published, and they have been published over the last 10 to 20 years. Where do we go from here? I think, as I mentioned when I first started, grateful to the Emirates Cardiac Society for starting this conversation. But let's take it somewhere. You know, the last thing I tell my son is, please stop whining. Nobody wants whiners, right? So let's stop whining about this. We know the data. It's out there. It's real. Where do we go from here? Where we go from here is, first, we recognize that improvement is needed, and there's more to learn. Personally, when I finished my fellowship training in interventional cardiology, there wasn't much talk about MINOCA, myocardial infarction and non-obstructive coronary artery disease. This is something that happened after I was already in practice, but we've seen it. This is one of our patients, this is a published article that we did with our colleagues, where this patient came in with a quote-unquote non-ST elevation MI. The coronary arteries were normal, and you're tempted to brush it off as, nothing. But actually, we did an MRI, and you clearly see an infarction. So this patient had a myocardial infarction, even though it was very limited with this orange bar over here. And then you see this patient on the left-hand side who had spontaneous coronary artery dissection. So these are new entities that we're learning about, and we're learning about them as we go. Are they exclusively in women? When we first started the conversation on SCAD, many of you will remember, it was something we all assumed it was something that has to do with pregnancy. Well, no. We've learned that it's not only associated with pregnancy, and it's not only a disease of women. So as we started treating women, investigating women who came in with quote-unquote normal coronary arteries and a clear non-ST elevation MI, we learned more about how to treat these entities that impact men as well. So we are learning, should we be using cutting balloons? Should we be stenting these patients who have SCAD? We don't know, but the data is emerging. A lot of it is emerging from other parts of the world, and we're hoping to jumpstart something here more regionally. But again, continuing with this theme of recognizing that improvement is needed and that there's more to learn. So again, when we look at revascularization and we look at complete revascularization, in the syntax, the 5-year mortality rate was higher in women who had PCI compared with those who had CABG. But by 10 years, that difference had waned off. And so based on that, the Syntax 2 2020 risk calculator prediction model actually removed the female sex as being a marker that we add as we calculate the risk in these patients. But as an interventional cardiologist, what can I do, for example? And I think we all need to ask ourselves that along the course, whether we're talking about interventions, whether we're talking about imaging, obstetrics, and so on. For me, for example, I learned that radial access, we do need to start giving women more radial access and reduce the risk of bleeding. And this publication actually suggested that women have a greater benefit from reduction of mortality when they end up having radial access for their procedures. The whole concept that women have smaller arteries that won't accommodate a bigger sheath or a bigger guide, we've learned is not necessarily true. Ultrasound guidance can actually help us. Intracoronary imaging, again, I just showed you the examples of Minoka, where doing intracoronary imaging as a baseline, female sex was independent negative predictor for undergoing an intracoronary imaging in PCI, generally speaking. So perhaps we should be adopting it a little bit more and understanding a little bit more compared, getting standard based on body surface area. And finally, this is what I said about complete revascularization. Women with incomplete revascularization, i.e. they have a residual syntax score, are more likely to experience major adverse cardiovascular events, including death and MI and so on, even after you adjust for age, after you adjust for comorbidities and so on. So we do know that we need to be offering these women complete revascularization, and so we need to think twice of which revascularization strategy we're going to offer these women. So I'm going to stop here, and thank you for having me. But at the heart of it, gender differences do impact cardiovascular disease. We should be joining forces, exactly as you have recommended that we should be joining forces. I presented this slide about a month or two ago when Dr. Shireen al-Sheikh in Bahrain opted to do a very similar, start the conversation. How do we start the conversation? Again, I'll give you an anecdote. When I came back from the US, interventional cardiologist, and all I want to talk about is stents and, opening and so on. I had a patient of mine who was pregnant or wanted to get pregnant, but she had cardiomyopathy that was induced. She had breast cancer that was treated, but she had developed chemo-induced cardiomyopathy, and she was asking about getting pregnant again. At that time, the data was very limited. So this is about 13 years ago. Today, we have something called cardio-oncology, and you can start these conversations. And let me tell you, whether I am as a cardiologist or me myself as a patient, I chose a woman cardiologist, because you can have these open conversations with them about pregnancy and about your value as a human being. You feel that this is your value when you want to talk about raising a family and so on. You may feel like you can't have that conversation with a man. You may feel you can, but I think we need to have that option for women. So when I say career development, we need to get more women involved, whether as cardiologists, whether as health educators, as social workers, and so on. So at least the women have that option. When I joined my center, I was the only woman, and I was the only interventional cardiologist in the region for over 8 years. I don't think that's fair for women who want a woman to have that conversation with. They need to have the option. If they want to speak to a man, good and well. But if they're uncomfortable and they want to have that conversation with a woman, we need to do that. We need to have training programs, workshops, scientific sessions such as this to raise awareness and do it. We do have to recognize we have a unique population. We have unique healthcare systems, and we cannot be adopting data from other parts of the world. We need to generate our own so we know how to treat our patients. And then what do we do with that data? Well, quality development and system improvement, and where we go from it. Finally, I think we need to speak the language of our patients, whether it is in Arabic, whether it is in English, Italian, what have you. This we just published with the Asia Pacific Women in Innovations Group. And this infographic may not be representative for women in the Middle East. They may want something more like this, where they see a woman in a hijab and what have you. It's fine, tailor it to the community you're addressing. Don't tailor it to what's happening internationally. And I think this is the platform that we need to be discussing it in. Let's tailor it, and let's move on and talk about cardiovascular health and not just disease. Thank you.